Okay, hi everyone, and welcome to the Out the Blocks Workforce Planning webinar. Today we're very lucky to have a couple of speakers with us who will be answering questions from myself and Pumi and yourselves as well using the chat function. And I'll introduce them just in a second. So the rationale behind this webinar was that we often get talks from our peers in SEM world about commissioning, and we have a rough idea of how it works from that perspective. But I think up until now, we've not had lots of teaching and not been able to learn as much from the commissioners themselves. There is some workforce planning information coming on the faculty website, which we'll go through later, which looks at a bit of a commissioner's perspective. But we thought it'd be great to pick the brains of the people themselves on this webinar today. So today we've got with us Dr. Imran Sajid, who's a specialty pain and MSK doc working at Charing Cross Hospital, and he also works across various MSK community services, and he also still works in primary care as a GP. And now his role in commissioning is that he's the North West London MSK and Diagnostics clinical lead. We also have with us Dr. Lesley Perkins, who's a GP in Tower Hamlets, and she's the co-clinical lead for MSK and pain in North East London ICB. So they'll be answering the majority of the questions today. And obviously we're very lucky to have with us Pumi Senaratne, who's an SEM consultant in Nottingham University Hospitals, and she's the Out the Blocks Committee chair. So she'll be leading on the first few questions, and I'll just hand over to Pumi now to open the chat.
Hi everyone. Sorry, Ed, I'm not the chair. Sonia Baines is the chair, but I'm one of the committee members. Sonia's away today, so unfortunately she can't join us. Thanks again to our speakers for joining us. My first question to both speakers is, could you just tell us a bit more about your role and the funding structure of MSK services in your area?
Shall I go? Okay. I'm at a slightly odd trading pathway, like Ed said. Most of my clinical work, I'm somewhere between an MSK and a pain physician. So I work at Charing Cross Hospital. I work in a tertiary tier 3 pain unit at Chelsea Westminster with psychologists and advanced rehab physios. And then I support various community MSK services in different kind of SEM pain roles. And I still do a bit of GP work. I used to do a lot more academic work. I was a lecturer in public health, but I just don't have much time for that anymore. And policy-wise, for North West London Integrated Care System, I'm the MSK and Diagnostics lead. So what that means is I sit on lots and lots of different committee meetings where we might look at designing pathways, developing or approving business cases, appraising evidence, trying to have discussions about what we should and shouldn't pay for on the NHS, and maybe sometimes identifying problem areas of kind of low value care that we might want to work on. Lesley, do you want to come and introduce yourself?
Yeah, sure. So I'm a GP, and most of my time has been spent being a GP. And about 10 years ago, I came into kind of a clinical leadership role, originally as a diagnostics lead, similar to Imran, but then about 6 years ago as one of the MSK and pain leads for our North East London area. And again, very, very similar to what Imran has said, I tend to spend a lot of my time going to meetings for various different kind of areas. And I think probably recently have been doing a lot of work on our community MSK business case. So I'll definitely have a little bit to say about that and the kind of challenges in the current, I suppose, climate within the NHS around that, and how we've managed to kind of who we have to convince and who you will have to convince when you're looking at thinking about how to kind of get your services commissioned. So yeah, I spend a lot of time in meetings and kind of trying to think those things through. And quite similarly, I think to Imran is that because I came from a diagnostics background and diagnostics clinical lead role, is really understanding the role of diagnostics in the end-to-end pathways, which I think are really important aspects which often get missed out in thinking about kind of general services. So yeah, that's my background.
I mean, I guess it's a big question with regards to kind of how MSK services are commissioned. I thought I might try and just whistle through from top to bottom all the different segments of the health economy. So you get And this is more just MSK rather than broader SCM, because SCM can kind of interface with other non-MSK services. But when it comes to MSK services, you've got these scattered, centrally funded kind of super specialist tertiary units. So this is what historically was called specialized commissioning. So in Northwest London, for example, we've got a chronic fatigue service. We've got a lot of services at the Royal National Orthopaedic Hospital. So these are things that at some point in time were set up nationally with contracts managed centrally by NHS England. Those things, as an integrated care system, we don't get involved. Those are funding contracts that sit outside of our allocation for local services. They're usually highly specialized, non-routine skill sets. So you will often see SCM consultants who kind of carve out a niche in a very, very specialist clinic. It can often be very unique services which don't necessarily have to be scaled as a routine model of care across the sector. Next level down, you've got your standard kind of secondary care NHS trust providers. So as an ICS, we manage lots of acute contracts. These contracts are paid in very different ways. Some of it is paid on activity according to national NHS tariffs. Some of the contracts kind of moved into block contracts during the pandemic. Trusts all generally have areas of activity which may be cash losses. So for example, emergency departments historically are cash losses for providers versus kind of cash generating areas of activity like, I don't know, ultrasound guided injections for radiology can be quite lucrative based on how much they're getting paid versus resource you have to put in. And trusts will all have kind of individual influences as to whether or not they can expand business in certain areas of activity or certain departments within their trusts. So trusts might say, well, we've got a long waiting list in this department. We need to commission something new, recruit some more consultants. But then they might have pressure from the ICS saying, well, actually, you're overperforming as a trust. We've got to put a recruitment freeze on you. Or there might be signals, for example, from GPwER model hospital data, which tells us actually as a trust, you already have a very beefy department. You're spending a lot on consultants. So that might be another thing that might influence whether or not hospitals are allowed to recruit more consultants. And we pay a lot of attention to the costs in secondary care. We kind of always have over the last decade in commissioning. And if it's one thing that you take away from this meeting, I really want to emphasize the fact that these are largely like fixed costs. It's like supply-driven costs. So whenever people talk about, oh, there's this new fancy treatment for knee arthritis, and you'll save loads of money because it's cheaper than what the orthopedic surgeons will do for knee arthritis. Or there's this clinic in the community that can do the same thing for a lot cheaper outside the hospital. It'll save you money. It very rarely saves us money because we have fixed costs. There are a certain number of consultants who are hired, who have access to a certain number of clinic rooms, who have access to a certain amount of theatre space. And no matter how much activity you might take off, you might slightly impact waiting lists, but you're never going to take out enough activity to actually contract the spend that we have in secondary care. And even if you look historically, there are loads of high volume procedures that secondary care stopped doing. In pain, there's all sorts of spinal injections we stopped doing. Orthopedics, lots of high volume stuff, decompressions, slap tear repairs, meniscectomies. That activity kind of dropped off, but there's so much stuff for secondary care consultants to focus on that you can never really contract those costs. So all this new stuff that we say in the community we can do, it'll save costs. It doesn't usually actually contract costs in secondary care. You have your community MSK providers that we, as ICSs, we do commission these, we procure them, we set them up. We have a lot of influence over these contracts. Most of that funding is kind of set up on kind of historical financial envelopes in terms of how much CCGs or now ICSs just have to play around. We have to be very careful on the spending because at least in London, we're increasingly spending more on our community MSK outpatient services than we are in our secondary care outpatient services. A large part of the health economy is primary care. It's a low unit cost, but high volume activity. And a large part of MSK activity is delivered in primary care, both by GPs. A lot of the GP stuff is probably low value. And again, it's not easy to release cash from these contracts, but I think we can definitely do stuff to try and support primary care with these patients. There's first contact practitioners. That's funding that was kind of shoehorned into the ARRS funding for primary care, which we don't really have influence over. That's a central NHS mandate. And the other big bit of funding, which is probably very, very kind of high value for buck, is health coaches and social prescribers, which are also put into the ARRS funding in primary care. Like Lesley mentioned, a big part of the health economy is diagnostics. Rheumatology testing can be quite cost pressure, and radiology, your radiology structures, which is both scanning and procedural interventions. That's a very, very big part of the health economy. You get a lot of clinicians who might normally work in MSK services, that's actually going to work in radiology services doing ultrasound guided injections, because again, it can potentially be quite cash generating. A big part of the health economy that we probably don't partner with and collaborate enough with is the third sector, particularly with physical activity. We know that with a lot of our MSK stuff, probably don't need to be as specific with movement as we think, and actually just general rehab principles, which third sector can deliver very well, is a large part that there is a lot of funding out there that we should work more collaboratively with. And I will just mention the private sector because I mean, I look after some of the richest postcodes in the country and some of the poorest, and the private sector can influence how your data looks sometimes. So there'll be a lot of patients in some sectors who walk up to primary care, you never see them again because they go to the private sector. And the private sector kind of is important because there are a lot of services that patients sometimes expect or want, which for lots of reasons are just not going to be available on the NHS. And sometimes there are certain groups of patients that actually probably their needs will be better met by the private sector. But I will stop there.
So
by the way, I speak very quickly, which I apologize for, but this is being recorded, and I'm very happy for any of you to reach out to me if you want to chat about anything, because I do love these discussions, but I apologize, I speak very quickly.
Sorry, Imran, I might just pick you up on one of the things you said there, just while we're on the topic, if that's all right. So you said that sort of taking services into the community doesn't necessarily save cost for secondary care. But could you put that forward as a business case to say that it might improve quality of care or waiting lists in secondary care if that is the case?
Yeah, and I was going to come on to that in some of the later questions where we're looking at value, because yeah, absolutely. So these are usually put towards finance committees as saying this will be cash releasing, and it's just a way to try and persuade finance to let us commission these. But often what you might do is you're not going to reduce the volume going into secondary care, but maybe you can improve the case mix of patients going into secondary care, so that actually the patients who need interventions will get there quicker into secondary care. And like you said, perhaps we can deliver more, we can reduce the amount of low value clinical care going on for certain groups of patients by delivering it by people who have got other skill sets in the community. Low value, well, I'll talk about low value later.
Sorry, Lesley, I'll let you carry on.
That's fine. I think I would add to that. So I think, you know, recently we've been doing this business case to try and increase the capacity in our community services. And we recognise that the main element from a secondary care perspective is we'll reduce the waiting times into our secondary care services. And currently, at the moment, we have a very low conversion rate to surgery for people who end up seeing our orthopaedic surgeons. It's something that between sort of as low as 20%, which then you're a bit like, well, actually these are surgeons and actually their best kind of value is in operating or in kind of having a discussion about operations at least. And so actually the thing that we've been able to say and demonstrate is that by increasing capacity in our community services, then we'll have an increase in the conversion rates to surgery, not obviously to 100% because that's not realistic, and there are some people who do need to see a surgeon before they make a decision, but also then you're then kind of potentially changing the waiting lists for your actual surgical procedures too, because you're seeing patients, or the surgeons are being able to see more patients who will ultimately need surgery, and then they get their surgery. There is a whole other aspect of that, which includes theatres and theatre efficiency and all of that, but that's not necessarily for this conversation. So I would just echo that, you know, it's still important to consider that care closer to home or care in community services is a good thing to write within business cases. But as Imran said, it might not necessarily be cash releasing. I think the only example I would use for us in North East London, which has been really key, is that actually we found in the last 18 months that about 40 to 50% of our MSK secondary care kind of services are actually delivered by the independent sector. So we're spending a lot of money in our independent sector providers who provide for the NHS. And actually for us, that the increase in capacity of our community MSK services from a commissioning perspective will actually release cash from that independent sector, and potentially put it back into the our acutes. Most of our, if we can get more of our patients being seen in our kind of large hospital providers, then that kind of repatriates a sense of that money coming back into the kind of NHS services. So that's a slightly different element, but that's where we are in North East London. I think The other thing I just wanted to highlight from what Imran said is that there are these different ways of contracting. So for us, a lot of the time before COVID, most of our services in secondary care were effectively payment by activity. So you see a patient, you get paid for seeing that patient. In a new appointment is a different tariff to a follow-up patient. COVID completely changed that for us particularly, and I think also across the country, into much more what we call block contracts. And so you get an envelope of money, you have to spend out of that envelope, and it's up to services to decide how you do that. In the kind of post-COVID, so like after 2023 kind of period of time, there's been for us a really slow transition back into payment by activity. And for some of our services, for example, our SEM services locally are paid by activity for initial appointments. So new appointments are paid by activity, but follow-ups are within a block. Now, that's probably quite complicated from a contractual perspective, but that's how it's working for us. But there are just these little bits to consider when you're starting to think about business cases for your services to be commissioned, is to think about the kind of types of the ways in which your local areas are commissioning in relation to contracts. So that's just another pointer in terms of kind of the way that things are funded. I think in terms of the other stuff that Imran said about the third sector, I think it's so important, and I think it's going to be increasingly important. So one of the biggest kind of issues, I suppose, within the NHS is inequalities or inequity in access to care, and MSK care is one of those areas. And so it's really important that we think about how we collaborate with the third sector, or how you collaborate with the third sector in order to get the best value for patients, particularly whether it's from a sports and exercise medicine perspective, maybe advising more in the kind of public health realm. And I'll talk a little bit about that later. Yeah, I think that's everything I was going to say on that, but happy for any follow-ups.
Thank you both. That's really helpful. Just the next one, you kind of slightly answered the next question, which is about how are MSK services commissioned in your area, but the kind of follow-up bit to that, what's the process and frequency of recommissioning? Kind of how does that work? And what are the main considerations when you're commissioning an SEM service? Shall I ask Imran first maybe, and then Leslie,
sure.
if we give Leslie a bit of a break?
So yeah, so since kind of 2015, we've had, it was PCR, public contracts regulations. We've had a decade of these competitive tenders, very much an open market where basically anyone can come in and say, look, we've got the skills that meet your service specification. There was a big change in technically it happened in 2023, where we've gone to PSR, which is this provider selection regime. So the market's changed a little bit now that commissioners or integrated care systems, they can actually just direct award the contracts that they have to their same incumbent providers. There's lots of rules about when you can and can't do this, but it's not necessarily as open a market in the sense of actual procurements as it used to be. And the thinking behind PSR is because it can reduce kind of admin burden, speed up processes, kind of reduce service disruption, and it kind of just somewhat stabilizes the market. That's somewhat offset by this new thing as well that's come in the last year or so, called the NHS Choice Framework, which is another massive kind of new thing in the NHS, where actually any provider can come into a local ICS and say, I can deliver this consultant-led service. I don't necessarily need to meet any of your local service specifications, but I hold an NHS contract somewhere else. Put me on Choose and Book or ERS, and any GP should be able to refer to me. And this is, I mean, Leslie alluded to this, one of the problems that, lots of independent sector providers that can just come in and they can try and cherry pick parts of the health economy, which are very cash generating, like often interventions generally are very cash generating. So people can come in and say, we can do all these ultrasound guided interventions or this or that. So there are these different pockets of funding, which if you are quite business savvy, you can kind of come into the NHS and get money for it. We do have a lot of Leslie was talking about this, non-contractual activity, whether it's diagnostics or other areas of kind of activity, which we as commissioners don't really intend on paying, but it's just these loopholes where independent sectors, and I don't have a problem with independent sector, just by the way, like there are things that the independent sector do very, very well, but it can be problematic as a sector when you can't control local pathways and have integrated services. The thing about procurements that I think a lot of people don't realize, because people sometimes get in touch with us and say, oh, we've got this business case. I think a lot of people don't realize how many years of planning go into a procurement. So most of the procurement, I've been involved in about 6 or 7 procurements over the last 12 years. Most procurements, you start planning 2 or 3 years in advance of the procurement date. You have to get it on the radar and agenda of lots of different people who have authority in your ICS for years before you can get to a point of developing a business case, let alone getting that business case pushed through. The sector procurement we did in 2023, that program of work started in 2020. And then when we're trying to procure services, there's always this kind of conflict about whether you kind of procure locally or globally at scale. Generally, we are increasingly trying to procure at scale, procure things and design systems as an ICS rather than individual boroughs. And because you're doing something at scale like that, and you're going to spend that much huge amount of program resource on a procurement process, we generally procure in longer cycles now. So if we're going to commission something, we're normally going to say, look, 5 to 7 years minimum, both for us in terms of how much effort we put into that process. And also as a provider, you kind of want a long contract in order, if you've got lots of capital costs, you're not going to take a contract where you're barely going to start making money back before the contract gets taken away. And just one thing that came to mind, so there are these new kind of social values elements that we score in procurements, which are meant to try and incentivize providers working more with the third sector. So like Lesley and I both mentioned, as a provider, you can actually partner up with third sector. You can outsource some of the money that you have in your NHS contract to the third sector. And some of the new ways that we score procurements are actually putting weight on your social value input to the population. And like Lesley mentioned, the way you pay massively influences your service. So every procurement, depending on kind of the current financial climate in your ICS, you can pay. There aren't national tariffs for physiotherapy per se. A lot of these community services, we kind of have to make up what we think a package of care should look like. And you can pay on activity, like Lesley mentioned. You can pay on a package of care. So a patient that goes through the service, regardless of how many level 1, level 2 injections, whatever they have, it's just a package of care. You can do risk share models where actually the provider can get a little bit of extra profit if they manage to meet certain targets to keep people at hospital. That works very well for like short-term gains. Or you can have, normally what we often do these days is a blended model. So we'll say to a provider, we'll give you a block of money, which just kind of gives you security in terms of your overheads and workforce. And then something like maybe 10, 15% of your contract value, that will be paid on specific outcomes, key outcomes, KPIs that we're going to agree on. And then other things to think about. So every sector might have specific policies. These used to be called PPWTs for areas of low value activity, whether that's around imaging or certain injections, interventions. That's something just to be aware of, because certain sectors might say we're not paying for this, or we're only paying for this in certain areas. And one of the biggest thing that I learned when I was doing this is we know that we have a big evidence practice gap, right? In terms of what the studies say, 20, 30 years when research comes out to clinicians changing behavior. There is a huge evidence policy gap. Policy is not just about what's the right thing to do, let's do it. I often joke that you could have kind of a cure for cancer that's relatively cost effective. And unless all the other stars align in the system, you won't get it put through. People just won't implement it. There was this old concept from like 1970s. It's the Carol Weiss taxonomy of research and policy. And it has like these 4 levels. So the top level is like knowledge driven, where all your policymakers have their ear to the ground. They understand the specialism. They understand all the research. Never happens, generally. You've got a problem solving level where actually whenever there's a specific problem to address, like maybe how do we commission MSK services, your policymakers will go out and they'll look at all the research around that in a really independent way. That rarely happens. Maybe sometimes it does. There was a natural experiment in the 70s where they actually gave policymakers loads of control over how research was spent, so that research would actually answer policy questions, and it didn't work for lots of reasons, because research and policies actually there are lots of things about them that are incompatible. You have this interactive model, which is probably what happens in reality, where evidence that's out there is one voice in terms of all the voices amongst the stakeholders that influence what we commission, what we don't commission. And then the most rubbish layer, which happens all the time, is kind of this symbolic level of evidence use, where it's just cherry picking of evidence to support your pre-held idea. So politicians do that all the time, podcasters do that all the time. And there are lots of these frameworks out there. So there's something called the Kingdom model, there's the Halls model. And what they basically highlight is all the other things that have to align for you to be able to push a certain policy through. And like I said, the actual kind of strategic policy, the evidence is just one small part of that. And the thing is, if you're outside of the commissioning structures, no matter how much theory you learn, you're just not going to know what's happening internally in an ICS that might influence whether or not a business case or procurement can go through. There are so many bizarre and random things that can happen within a system that suddenly make a business case that's almost gone through suddenly get failed at the last minute. And the best thing you can do about that is just relationship building. So you've all probably learned about stakeholder mapping, figuring out who your allies are on the system, who has power and who has authority. I mean, I'm someone who I have a little bit of influence. I have zero authority. We have various people on different committees that have authority, but you need to figure out who the people are in your ICS that you can develop a relationship with, have over coffee conversations with. In terms of how it should happen, this is how it should happen, which is not necessarily how everything does happen when we are commissioning MSK services. First, someone proposes something, you say, I've got a business case, this is a really good idea. Number one, it needs to meet clinical effectiveness. And different ICSs will have different skill sets in terms of how much they're able to interrogate clinical effectiveness. It is very, very, very difficult. It's a skill set in itself to be able to interpret evidence to say that something is actually clinically meaningful. Secondly, is it cost effective? Loads of different, people have business cases which show loads of different things. You can have a cost benefit analysis, which is monetary. You can have a cost effectiveness analysis. You can have a cost consequence analysis, which is my personal favorite, and we probably don't do it enough. Next, affordability. Can your ICS afford what even if it's clinically effective and cost effective, if the ICS just can't afford it, that's a non-starter. Next, ethical implications. So that's things like a equality health impact assessment. Next, legal implications. There's all sorts of legalities behind all these contracts that we hold. Most procurements, we spend long phone calls with lawyers just to try and figure out what we can and can't do. And then finally, all the big stuff in terms of, is this feasible? Is this implementable? What's the political appetite locally? So you have to go through all those stages, which, like I said, this takes 3 to 4 years if you're doing a big MSK procurement across a sector. I'll stop there. Leslie?
I would totally echo that. So what I would just say up front is that, so our musculoskeletal business case for increasing capacity in community MSK services, which is something that has a very good evidence base for quality of MSK care, has taken us 6 years to get to this point. And partly that was a COVID related issue, like partly, but that was just 1 or 2 years of it that was that. But I've been to multiple boards where I've presented the business case in its conceptual form, as well as in some of the financial elements of that form. And I've had lots of people pat me on the back and say, oh, very good, this looks brilliant, excellent, well done, excellent. And then you're like, and so can we? No. And a lot of the time it's what Imran said, actually, yes, we understand the evidence base is there. We understand that there's a cost benefit or a cost effectiveness element here, but we don't have the money, or sorry, our priority is somewhere else. And there'll be different priorities, and some of those priorities will be nationally driven, and some of those priorities will be locally driven. So I think part of the reason that we've had some acceptance of our current MSK business case, and this is at present not to completely re-procure, it's actually to just get extra funding into our community MSK services, and we've had to demonstrate that we'll find the money from somewhere. For us, it's going to be from switching off MSK MRIs in primary care, which is another element of what we're doing. So I would just say that, I totally echo what Imran's saying around how long this takes, and relationship building with finance. I would definitely recommend finding some finance people that you can get to know. But also I think that locally for us, our sports and exercise medicine services have been around for a really long time at Barts and the London, and also they're involved in research and education as well. So they've had quite a good kind of from a commissioning perspective. It's been commissioned for a really long time, and we've never sought to recommission our SEM services. And all of them locally accept GP referrals, as well as A&E referrals, as well as some of them self-referrals. And we've got one of the kind of I think there are 3 NHS dance SEM services in the country. This is one of them. So I think there's also that, isn't there? Like for your service, is there a particular nuance that you hold in your local area that actually is the right thing for your population? And sort of having an understanding of that, which is where I think some of your I think many of you in training get a public health section of your training. So that's really like a really good thing to know if you particularly want to be trying to get services locally commissioned, is really understanding your population. And as you know, are you going to really be able to meet the needs of that population from a sports and exercise medicine perspective? I think those are really good things to consider. And yeah, so I think I would say start early, build those relationships for sure, and consider primary care as well. Consider who your allies are in primary care. Most of our sports and exercise, so until recently, for us, our sports and exercise medicine service has been hidden within rheumatology. And actually, most GPs, I don't think SEM, rheumatology. We don't put those things together. So actually the service is probably underutilized. And it's only recently that we've agreed that they can sit outside of rheumatology and be a directly bookable service within our area. But that's taken ages, and it's really the relationships with primary care that they had previously developed that meant that their referrals were coming in and they're getting a good level of people coming through their service. So I think that's also really important to have a good primary care relationship locally. And I think some of your trainees will be GPs originally, so there's also kind of making use of your peers in that sense and their understanding of primary care as well. I think that's mainly the kind of things I would say. Commissioning isn't as straightforward as it maybe should be. And there are stars have to align in some ways. I think the main other thing I would say is that the current climate is that lots of the ICSs and ICBs are basically having to reduce their own operating budgets and the number of people within the ICBs. And so there's quite a lot of turnaround in staff within ICBs. So that's why the primary care, third sector, very local organisations are the people that you could build relationships with from a long-term perspective in order to kind of really understand what your services could deliver.
And just to add on that, there is probably more money going into primary care, these new integrated neighborhood teams, etc. So that's where there's a bit of appetite to spend money, whereas at least in my sector, we're overperforming. So the constant message is there is no more money for anything in the community. There's no more money for anything in secondary care. But, the current national drive, NHS England is telling ICSs to contract, but integrated neighborhood teams, primary care, there are more revenues of cash kind of going to those areas if you've got novel models of care.
Brilliant. No, thanks so much. That's actually clarified quite a lot of things, I think. I do have just a couple of questions to come back on just before we move on to the next question. So if you're wanting to sort of break into a local area and you want to commission a new service, does that have to happen at the point of procurement? So say the procurement happens, you're then contractually obliged to do something in this way for a certain amount of years. Is it possible to then divert towards commissioning in a different way during that time period?
So I guess it depends. So there'll be a service specification for that service, but services always evolve what they're doing. You have contract meetings. So if you're talking about community MSK services, we constantly change the service model. So that conversation is actually probably more to be had with the service provider who holds the contract. So if you're saying, look, we can offer a slightly different model, and the service provider can say, okay, well, this is the budget we have, and actually as a provider, if it's cost effective within our cost envelope to do it in this way, then it's your provider who has to okay that. And then usually the commissioners might be part of that conversation where you just run it by commission and say, look, we're going to do the model slightly differently, just to check the commissioners aren't saying, wait, that's mad. But it's absolutely so. MSK contracts should evolve every year. So we often review the service models regularly. We review the contract KPIs every year. So yes, it's not set in stone at the time of the procurement with the service spec, and the money might be set in stone. So if someone turns around and says, actually, we want X amount more cash per year, that's a very, very different conversation. But if it's operating within the financial envelope, absolutely, there's no reason why the model can't change.
Yeah,
And
I would agree.
no, that's good to know. And within that model, then, what specifically are you mandated to commission? You know, for say you've done an MSK service procurement, what kind of specifics would you be mandated within that to provide?
I mean, I'd be curious, Lesley. You've seen our service spec. I don't know how much yours differs, but a lot of service specs look completely different to one another. So you know, you've got completely different skill sets of people who, based on what their local need was at a time, they might have specific objectives and key principles of a service model that they put into their service spec at the time of procurement. And they'll often look different. You'll have some ICSs where they really have their ear to the ground and they really understand the landscape, and you'll have some that just have a very small limited team. They'll copy and paste service specs from other sectors. It ultimately just comes down to your conversation with your commissioners who run MSK to say, look, this is what we think might be better if it's not already in the service spec. But Lesley, you're in the midst of a procurement now, so you've probably seen ours and other service specs to talk about how different they are.
Yeah, I mean, I think that I would say that, just echoing from before, the work that has to go into doing business cases and service specs is that I think that there's a low bandwidth, right? So that whole thing about like, what are you doing in Northwest? What are they doing in Southeast London? Let's kind of take and have a look at those things and try and understand, does this really match our area? Does it need to look different for this area? So I think when we're looking, I mean, for us, because our sports and exercise medicine services are set slightly outside of our normal community MSK services, we haven't really thought about SEM in terms of MSK, although, and I'll say this a bit later, I think that's probably a bit more of the future that I'd like to see, to be honest. But I just agree. I think the service specs are different in different places, and they should be. So there should be variation according to local population, variation according to kind of clinical preference or kind of that kind of thing is probably unwarranted, or in access, for example. But clinical or variation in a service model associated with how your population needs might be met, particularly to reduce inequalities locally, is really, really important, I think. And so actually really knowing your area and knowing your commissioners and understanding what it is that they want to see in a service is probably the most important thing. So that relationship building is most important.
That's brilliant. Thank you so much. I'll move on to the next sort of question stream now, if that's all right. Lesley, do you want to go first on this one?
Sure.
If that's okay. So this one really is, so we've got the kind of idea of the general structure, where the money comes from, how it's commissioned and when. Now sort of flipping it on its head a bit, thinking more about what we need to think about as people working in MSK and SEM in terms of what we need to provide. So do you have any sort of specifics or examples of how you would demonstrate adding value? So as an MSK service, so when people are coming to you with business cases, what specifics would they present to you that would say they would add value or reduce costs or reduce waiting lists, as an MSK service? We sort of touched on it before, but it's a bit more specific, if that's all right.
Yeah, so I mean, I think in terms of sports and exercise medicine and what I would be looking for locally, if a SEM service came to me and said, this is what we think, I would, if you were wanting to be a service that was separate, so a secondary care service where people can directly refer into you or sitting within one of the other secondary care services, I would probably want to understand what is it that you are adding to the already massively wide scope of MSK healthcare that there is. So what's nuanced about your service? So for us locally, there's the dance element of our service that's helpful, and it's an NHS service, not a kind of elite dance necessarily service. So there's something around that. but I think probably for me, because I'm operate much more in the kind of community MSK space, and that's what I'm thinking about the most at the moment, I would say, like, in terms of community MSK services, you've got your kind of band 5, 6 physios who are delivering treatment physiotherapy. You've got your then GPs with special interests and your advanced practitioner physios. And could you, or does an SEM consultant or trainee or registrar sit within that kind of band of people within a community MSK service? And what else could you provide there? What are the kind of more medical approaches, or the kind of more, or the more holistic whole person approaches that you as SEM consultants do and could provide within that context? Also, particularly thinking about pain, and pain being a really massive element of MSK healthcare, just thinking about how you also interface with pain and pain services that sit within community. So I'd be wanting to think about, how do you add value there? I understand that there are certain services that take, that have that deal with more of the complexity around pain. So how could you, add value in that perspective? Which patients could you be seeing who would then not go up into a secondary care pain service, and things like that? I do also want to understand how you can contribute to triage. So how would you contribute to MSK services triaging patients appropriately, either into yourselves or into secondary care orthopedics, or who they're seeing within a community MSK service? So I'd kind of want to understand that. And I think there's something about the kind of elements of care that you bring around understanding some of the things like the metabolic impacts of, or metabolic disease impacts into MSK health, some of the women's health stuff that maybe that you could get involved in from a sports and exercise medicine perspective, and kind of liaising there. So I'm looking for, like, actually, what can you contribute to a multidisciplinary approach in MSK healthcare? Those are the kind of specific value elements that I would also want to be looking at. And like I said earlier, and like Imran's alluded to as well, is just, how are you collaborating with our third sector colleagues? How do you think about the exit strategy out of a community MSK service for a patient from an end-to-end perspective? So if a patient's coming into your service, what's their exit strategy? So who are they going to be seeing after you? Who's going to help maintain some of their care, or some of their habitual change, or whatever it is that you have supported them to get better in? How are you interfacing with community and primary care and the third sector, and using some of your skills in your public health learning to do that, from everything from supporting exercise setup groups, and also I think some of the things that some of you do in your training is get access to kind of sports organizations, for example, and actually leveraging, sorry, that's the word, leveraging some of those relationships for a local area is actually really important. Thinking about how can those organizations support people to move better, move more. Those are the kind of things that I think is you as a specific area of MSK health can really add value, particularly in community MSK services. So yeah, I think those are my sort of examples of where I would say definitely add value and would emphasize those.
And would you want to see evidence of that if they've been working somewhere else prior to trying to commission a service, or would it be a sort of theoretical what they could provide?
I mean, ideally an evidence base. I think the tricky thing about outcomes, and I'm sure Imran will talk about outcomes a little bit, is that I'm sure for sports and exercise medicine, there are multiple different outcomes that you are looking at whenever you're treating a patient. So actually, yes, an evidence base would be good. But as we've said before, there are other elements that really help us to understand, what we want to commission. So evidence base is a part of that for sure. And if you can evidence that your service can provide that, or your consultant sitting within a different service can provide a part of that, then absolutely go for it. But even sort of actually, how do we innovate now? How do we think about going forward? Because we can't evidence everything, but we do have ideas about what could work. So actually, I mean, this is me personally as a commissioner. I'm also looking at kind of, are you thinking of different ways of doing things, and not like crazy ways of doing things, or kind of things that are going to be too expensive or unusual. But I'm often looking for collaboration. How are you collaborating with primary and third sector? And that's really important, I think, and increasingly important, especially as those NHS, there's those 3 NHS kind of, I suppose, conceptual targets around community, hospital to community, increasing prevention, promoting health. And the third one has totally escaped my mind just now, but oh yeah, analog to digital as well. So there's also those kind of things. How as a commissioner can you demonstrate, either through evidence or through ideas or through things you've already done, project work, all sorts of different ways that you could demonstrate those things to me, and then I'd be interested in that sort of a conversation.
That's brilliant, actually. We've got one that's just come from the chat, actually, if you don't mind, if we just try and address this one while we're on the topic. So it's from Anna Marshall. So if you developed a role and service within the community that reduced costs at secondary care and waiting lists, for example, unnecessary referrals to secondary care, how does that money come back into primary care? Or does it?
It doesn't, and it goes back to what we were saying earlier. So all these things, these are always cost pressures. You can have a much cheaper alternative to something in secondary care, and we've been so focused on trying to reduce secondary care spend. You will not reduce secondary care spend unless you either persuade secondary care to start reducing theatre time, firing consultants, or in some way contracting the fixed costs that they have, or renegotiating some of the tariffs that you have with them. Their waiting lists are so long. And our systems, particularly in London, where these are not neat vertical systems, there's loads of activity coming from those places. So you're never going to skim off enough activity in secondary care, at least in most MSK specialities, that suddenly these consultants are going to be twiddling their thumbs and having time on their hands in secondary care. So that's the problem. It's not a case. And we as commissioners, these are completely different funding pots as well. So we can't reallocate money from one. Secondary care funding is completely different to primary care funding to community funding. So we can't rejig money between them. And going back to the value discussion that Lesley was talking about, so there's so many different ways that you can go into like a whole philosophical debate about what is value in healthcare. A lot of what Lesley was talking about, you should try and paint a narrative which fits your ICS's specific strategy. So in North West London, for example, we've got specific strategies around patient activation, long-term condition management, supporting primary care, reducing the distance between primary care and secondary care. So whatever you're trying to sell, it needs to meet the narrative of your local ICS strategy. And there are very simplistic ways you can think about value. So there's this concept of low value healthcare, which is stuff that's clinically ineffective or cost ineffective or harmful. But I would really encourage people, if you're interested in the concept of kind of value in healthcare, there's really great stuff from IHI or Samir Gray on kind of these wider frameworks of how we measure value in healthcare. So kind of one of the nice overarching frameworks is this whole triple aim, which some of you may have heard of, where you look at there's 2 areas of value which we are rubbish as commissioners at measuring. So one is kind of allocated value, which looks at kind of population health, social determinants. It's really, really hard to kind of measure that stuff. And also often it's somewhat beyond the impact of kind of individual providers to be able to influence that very much, particularly if you've got multiple providers in your landscape. There's this whole concept of individual value in terms of what you can offer patients. So that's all around patient experience and patient outcome scores, PREMs and PROMs. All of us and providers know it's really hard to get that data. So the best I've seen is that about 20% of patients going through a service will have a pre and post outcome scores. So we're really, really bad. And even when we collect that data, we don't necessarily know, well, what's a good improvement score? What is the minimum clinical important difference on a MSK-HQ? Roanna Burgess and the team at Keele are trying to do a lot of work on that, but we are actually really, really bad at measuring the outcomes of most services in the MSK sphere. GPwER try, but there are limitations in everything, in all the indicators that we have. And really, most of the time, unfortunately, what commissioners look at and what influences most of our decisions is this very narrow view on technical value, so like technical efficiency or unit cost. You'll unfortunately get very frustrated sometimes where an ICS just wants the cheapest unit cost of delivery of a service, which, you know, if you're just driving down to the bottom, you're going to get worse outcomes. And sometimes you can just grow a lot of activity that you don't necessarily want. But unfortunately, finance departments are often literally just looking at what's the cheapest unit cost. What is a service that can deliver X number of outpatient appointments for the cheapest value? And that isn't going to necessarily get you the best outcomes. And I think all of us in commissioners, we really do need to be really scrutinizing everything that we do. We commission so much low value care. And historically, we've really focused on interventional treatments, surgeries. There's a lot of stuff that's kind of come up on the radar for NHS England, evidence-based interventions, lots of injections have been scrutinized, but we're spending so much in these kind of conservative, non-surgical MSK services. I do think we probably aren't as scrupulous as we need to be based on the amount of volume that we're spending on it. And, you know, we can commission things in the community, which sometimes just drive demand. If you've got a great service, you'll just drive demand. A lot of that might not be demand that the system needs. Historically, we've decommissioned a lot of community services and we get a bit scared thinking, oh my God, secondary care activity is going to shoot up. You can decommission massive community services. Actually, nothing happens to secondary care activity. So yeah, all these things in the community that we're paying money on, they're always cost pressures, and you need to just have a really good narrative, because we're often not going to be able to measure it, a really good narrative to make it politically acceptable for your commissioners to spend millions on that. And everything, whenever you need to quantify the problem, if you can quantify the problem, whether that's waiting times or patient outcomes, and you really need to be careful of unintended consequences. So everything we do has unintended consequences. The one unintended consequence, which I often kind of try and keep quiet about, if our community MSK services delivered what they're meant to deliver, which is you increase your conversion rate. So actually we make sure that only the patients who really need surgery get through, only the patients who need spinal injections get through, only the patients with inflammatory disease get through. Eventually what that will do will massively increase secondary care costs, because an orthopedic surgeon spending a session in outpatients versus a session in theatre, they'll start to say, well, actually our outpatient demand is going down less. We're actually getting more patients that need to convert to a surgical procedure. So they'll shift around their activity and they'll start spending more time on the high volume cases. So everything we do has unintended consequences. And yeah, it would actually, if our MSK services do what they're meant to do, we're going to have a big problem down the line where actually all the complex cases are getting through earlier to secondary care. And secondary care is going to turn around and say, we're not having delays in outpatient appointments, we're having delays to treatment, and we need to commission more theatre time. So everything it's a really complex system commissioning. Everything has unintended consequences.
And that's actually fascinating. It sort of leads into the next question a little bit. Well, the next question was going to be, what do commissioners look for in a new service? But I think we've sort of covered that in what we've been through there. So instead, I'll change it up a bit and just sort of ask, what are the challenges to getting an SEM service commissioned, or any external threats or any sort of pitfalls that you've seen in SEM commissioning that you've come across?
Lesley?
I think I would say that it's really important to get across what it is that you do. So the challenge is I don't think that not all people, certainly not all GPs, will understand what the difference is between what an SEM service or an SEM consultant or team deliver, as opposed to a different specialty within MSK healthcare. So I think that there's something around the challenge around people out there in the community and in primary care really understanding what it is that you do, like what you're actually delivering, what you can deliver, what added value you give from a clinical perspective that you have. So I would say that that's probably one of the challenges. And I think especially for us locally, as our services have been quite hidden within rheumatology, it's been a challenge for them to be actually utilised. So one of the only services I know coming to me going, please can we just do like a bit of a plug, for our services. So actually the underutilisation of our local services is been a challenge, I think, for us. Or for our services locally anyway. I don't know what your thoughts are, Imran.
Yeah, so I mean, I guess there are some good things. If I talk about some of the opportunities, I think at the moment. So I don't think it's about evidence. If you've got evidence, that's great. One thing I always tell people, whenever you do any kind of pilots or innovative models, you are meant to spend around 10 to 15% of your budget on evaluation, because evaluation takes loads of time. There's a lot of innovative work that happens out there that no one ever hears about. And you kind of need to partner up with various different organizations, whether they're academic organizations, academic health science networks, to do the legwork. You're not necessarily always paying for quality. You're just paying for someone to do it and then publish it and put it out there, put it on GIRF's radar, put it in future NHS case studies, whatever, to actually disseminate it. But it's not really about the evidence at the end of the day. The stuff that really helps, the fact that MSK is increasingly on the NHS strategy horizon. There's a lot of focus on kind of low value healthcare. A lot of the low value healthcare interventions are MSK related. So people are looking for ways that we can improve the evidence-based treatment in NHS MSK pathways. And there's a lot of focus on long-term condition management on the national strategy radar. And that's where these are like cross-cutting themes across lots of planned care, cardiology, diabetes, bariatric surgery, and MSK that SCM can potentially get involved in. So there are opportunities. I think the big thing that kind of Lesley alluded to here is kind of like, what is the role of an SCM specialist? I'm talking about here about medical consultants. You know, we've kind of, there's been a steer away from just looking at athletes to more wider long-term condition management, addressing the kind of multimorbidity and chronic MSK conditions that typically are high pressures on the NHS. So there is that kind of strategic shift. There is still this ongoing kind of dialogue in terms of, well, how do you use that workforce? Because all consultant workforces in the NHS are very limited versus the actual population demand. SCM is tiny in terms of that consultant workforce, especially the consultant workforce that works within the NHS. So there's this whole question of how do you develop a model of care that works? Because actually with such a limited consultant resource, patient-facing contact might not be a major part of that role. It might be more around leading a wider team with MDTs, education and support to primary care, education and support to APPs. And I think everyone's still trying to figure that out in terms of with SCM consultants. Number one, like Lesley says, there's an advocacy role in terms of saying this is the value that we offer above and beyond other specialties, and also figuring out what that model looks like, because a consultant's very expensive, and there are large elements of what an SCM consultant does that you can argue that someone else can do. Like there are lots of bits that an SCM consultant can do that a very advanced practitioner can do at a fraction of the price. There's a lot that maybe even a social prescriber or a health coach can do at a fraction of the price. So you have to say, this is a skill set, and this is the model of delivery, which will try and get it in front of the most people you can get it in front of. And I do think you kind of need to meet where the demand is. So like Lesley mentioned this earlier, there's like a really high burden of chronic pain and kind of associated psychosocial disability on the NHS. And if I'm thinking about kind of the high volume activity stuff, this is MSK related, thinking about where the wait lists are, thinking about where the low value clinical activity is in MSK. So I'm thinking about things like back pain. I'm thinking about all the chronic MSK conditions. So, you know what, like the majority of shoulder pain that comes to primary care, those patients will still have that at 1 year. The majority of plantar fasciitis that comes to primary care, those patients will still have that at 1 year. All the widespread chronic pain, which is a massive part of rheumatology pathways, unfortunately, which are non-inflammatory patients. All those patients with chronic overlapping pain conditions, which bounce between multiple specialties in the NHS, but often never really get their holistic whole person needs met. These are all areas where potentially SCM can really do something unique, but they do need to demonstrate significant added value above what other practitioners like APPs can do. One of my personal steer is probably that, and this is just, I'm biased on this because it's my own training, but I feel I would be very limited in what I can do for patients without my previous psychiatry and pain training in terms of those patients that we see really kind of being a burden on the NHS in terms of other clinicians not knowing how to manage these patients. And we know that there's just broadly, there's a very limited role for passive medical treatments for a large proportion of the MSK landscape. And we need a real narrative around kind of long-term disability management, which does involve a lot of managing psychological and social needs, which are not easy conversations. But I think SCM can potentially address that. And like I said, not just themselves direct patient facing, but they can support and upskill advanced practitioners, GPs, pharmacists, health coach, because there's no way you're going to get all the patients who would really benefit from seeing an SCM consultant in front of an SCM consultant, not in an equitable way anyway.
I think I would just add that I think, I mean, I'm also a little bit biased because I have not a not a special interest in the sense of training, but I have a real passion for persistent pain and kind of chronic pain and the disability associated with that, and how much of that sits in a primary care setting, and how much we hold in general practice with patients living with everyday pain. I think that there is a real opportunity, like Imran has said, for placing yourselves in that kind of space. And if you think about community pain services, they do occasionally have your kind of secondary care anaesthetist sitting within the kind of MDT. But actually, I think there's probably an argument that your skills are probably better placed than potentially than a secondary care anaesthetist in a kind of community MSK pain space. So I definitely would maybe think about that. I think it's challenging because they're patients which there's a lot that needs to be done there for patients. And again, this is where I think that exit strategy is how are we holding those patients beyond the care that they've seen within your service or within what you've been able to provide. So that collaboration in terms of primary care and upskilling primary care, that collaboration with your third sector colleagues in the local area is that really good exit strategy as well from those kind of pain services. I just completely reiterate that because I think it's possibly the place where there might be some really good opportunity.
And so obviously we sort of touched on it briefly there, but it's a good time to bring it in, I think, in terms of one of, I guess, the key pillars of our practices around exercise medicine. And obviously you're an MSK commissioner. Are you interested in us providing exercise medicine services part of an MSK service? Or do you think we'd be maybe barking up the wrong tree there and we need to go down a different commissioning route if we were to think about a more exercise medicine focused clinic?
Ed, so the mishmash of exercise clinics that I've come across in the NHS are all very variable in terms of what they specifically focus on. They usually tend to sit in certain different specialities. When you say, is there a specific, when you say exercise medicine clinics, is there something, what broadly do you mean by that?
Yeah, so it would be exercise medicine, physical activity advice, essentially for people with long-term health conditions and having consultations with an SEM consultant as part of that.
Yeah, so I think one of my biggest question marks around that would be, so obviously if someone's medically trained, there is a degree of additional complexity that they might be able to deal with. But if you look at kind of, I don't know, if I look at rehab clinics and other specialities, that it doesn't necessarily always need to be consultant-led. And considering it's a much higher cost to be a consultant-led service rather than a nurse-led service or a specialist health coach service, you just have to think, it comes back to that earlier thing. It might be clinically effective, although if you really scrutinize the evidence around behavior change, it's a very complicated topic. But is it both cost effective, if you're looking at just cost comparison between someone in the workforce who's potentially a fraction of the cost, and is it affordable? That would be the bigger issue. It's a nice to have, but I would have questions around the cost effectiveness and affordability of it's what we were kind of saying, echoing earlier, what's the added value of it being an SEM consultant? That's a very limited resource. It's a very expensive resource. To my mind, what it might look like might be led by allied health practitioners, but there might be an SEM consultant at the top who doesn't see all the cases, but might discuss some of them in an MDT model. But for that person to see everyone, I think would be very expensive. But there's definitely a role, and we often see SEM consultants sitting in exercise medicine within other, sometimes secondary care, sometimes specialized units, just providing exercise medicine advice. And I'm sure there's a lot of SEM consultants who have a specific interest just in exercise medicine. It's just, to me, it's how do you do it in a model that's cost effective.
Thanks, guys. That's really interesting because I as a reg, ran an exercise medicine clinic for a very short period of time, and exactly what you said, it's not sustainable. And like you said, if there's someone kind of running the MDT who's delivering that kind of makes more sense to me as well. We've actually got a few questions on, so I might just go through them if that's all right. So Stefan Kluzek, on practical levels, how do commissioners identify and quantify temporal changes, population needs in a specific region, and assess whether existing services are addressing those needs? You kind of discussed about that, but I guess, do you have any specifics in terms of, that's a hard question.
There's lots of ways that we do it. So you have certain data sets. So, you know, we have model hospital, now we've got GIRFT. Sometimes you might, certain boroughs, we don't do them as much as we should, might do a joint strategic needs assessment where you work with public health and you look at publicly available, you know, you look at what data is available and you try and address these things. Sometimes we will locally, if for example, we're doing a procurement, we'll commission a team to actually go back and trawl through data and see if there's a specific question to be asked. One of the things that we do sometimes, purely to get things past finance officers, is you bring in an external, people always get really infuriated. Why are we commissioning Deloitte? Why are we commissioning BCG, whoever it is? Part of the reason you do that is not because of quality, it's just because it's this.
Did we just lose him?
If you can't do it yourself, but there are lots of different models, and the problem is they're all limited because the data on a lot of this stuff is very limited. Lesley, I don't know if you've used any other mechanisms in your procurement.
No, all of those, but I would also say just having an ear to the ground in primary care. Like there's something about being a clinical lead in this context, being a jobbing GP, working in the area, and sometimes GP noise. I know this sounds a bit strange, but sometimes you're hearing some of what is going on the ground and you're thinking, okay, whether our services are delivering actually the kind of care that they say that they're delivering. Actually what I hear, and part of my role is to try and take some of that and piece out what is actually noise and what is actually true. So although that doesn't feel like a very kind of, you know, like structured way of thinking about it, part of what your role is representing general practice, or my role has been to represent general practice as well, and to kind of understand where GPs are ending up having to hold things which maybe that would be better served within a community MSK service or within MSK care as a whole anyway. And so that for me is where I've definitely heard all of some of the independent sector issues that we've had locally, and where we've really needed to kind of really scrutinise what the independent sector are doing and delivering in terms of the care that we've commissioned. So I would say there's also a part of me that thinks that that's important, even though it's a lot softer. And probably sometimes depends on the people that shout the loudest. So yeah, I would acknowledge that as well.
Thanks. Stefan, did you want to add something? Just I've seen your video feed pop up.
Yeah, no, thank you. Great answer. And obviously, question was very provocative because since I've been involved in public health and discussing health need assessments, no one ever had a proper answer. At the same time, everyone is commissioning different services and trying to assess what they do and how they fit the population. But as I understand the commissioning path, regular meetings, they publish at the moment what they feel the needs are. And is that something that is accessible to the public, so people can go back and say, in fact, there's a need in that part of the country that we can try to address by putting together a case?
What I would say is that locally for us, we also kind of consider what our Health Watch colleagues also do. I don't know if you've heard of Health Watch, but they tend to be an organisation who, again, are trying to listen to patient voices within the local area, trying to put some of that forward through to public health and to our commissioners. I don't know if that quite addresses your question in terms of whether the public can have a voice in this area, but I think we often go to our Health Watch colleagues to kind of make sure that we're not missing things as well.
I was more questioning, sorry, the internet probably is not that stable on my side, but my question was, do commissioners publish reports that people can access and review in terms of the health need assessment in a region?
Yeah, so they're not done as frequently as they should, but we do have joint strategic needs assessments done. And then when it comes to commissioning decisions, there should normally be various types of health equality impact assessments done. There's this whole push towards transparency. So everything that we commission, the case behind it should always be transparently published in different places. I would go back to what Lesley and I echoed earlier, that a lot of the time it's more the narrative that's put something on the radar in terms of influencing a commissioning decision rather than purely the data behind it. And it's not to say that we should just abandon data. It is a useful voice, but there are lots of other influences that will push something being commissioned. But yeah, there will be some document usually publicly available. If it's not on a website, everything through an FOI is usually available. But you could very easily unpick and say, well, it's not entirely clear why this decision was made, and that's because of just all the other influences that go into policy. There are kind of new frameworks that are trying to be kind of, the DMAT is a big framework that John Littlewood published at King's, and these types of decision-making frameworks try and make everything that policymakers do much more transparent. The problem with whenever you use these exercises, it can become a bit of a tick box exercise that like, oh, we've looked at this data, we've looked at this data. And people will say, yes, we've done an equality impact and a population impact, but it's just a tick box exercise. Ultimately, kind of goes back to what Lesley said earlier, there is a bandwidth limitation amongst commissioners. We can't always look at problems in as much depth and as detail as we'd want to. But whatever reasoning was there behind a commission decision usually should be publicly available. If it's not up there, you can definitely ask for it under an FOI.
Thank you.
Yeah, I think the only other thing I would say is that data, I don't know how you find this in sports and exercise medicine, is a slog. It is a slog to get really good data. I don't know if this is just North East London, but like just to get really good data to inform decision making, which is why you're trying to put together different areas of narrative, both that are data driven and some that are not, in order to make your decisions. But yeah, we should publish things, to be fair. I think that would be a really good thing if that was part of what we just routinely did. That would be good.
Would be nice to have at least some sort of short notice that after the meeting we are finding that this is an area of interest that we want to develop in the future, so people can go and think about that. So because I think that used to be a case in 2013 when I was still working in Reading, that commissioners, local authorities in public health at that point, were trying to publish what is needed in a service. So they were asking for people to create ideas about their service development based on the needs that they found being in a local authority at that point. That has disappeared, I think, since then.
One of the difficulties you'll have as well is that this kind of work can happen in lots of different spheres within an ICS. So it's just, MSK is so multi-stakeholder. Some stuff will happen in rheumatology, some stuff will happen in pain services, some stuff will happen in ortho, some in MSK radiology. And so it can actually, you often won't know which group is actually looking at this issue. Some sectors are a little bit better actually bringing all those stakeholders together in one kind of program board or network. But that's another big part of the problem, that like the work and the evaluation and discussions are happening very fragmented in different pockets of the commissioning landscape.
Thank you.
Thanks, guys. So next question we got from Kim Gregory. What are you looking for in terms of services to prevent the chronicity developing in the first place?
Lesley, do you want to go or shall I go?
It's such a big question.
Yeah.
Yeah, I mean, I think the things that I would say around it is very difficult to locate the responsibility for prevention of chronicity in a single service. We really need to be thinking about that at a multiple stakeholder level, starting even not in healthcare, or even in public health. We're talking about all factors or elements of society, really, in thinking about movement in general, to stop the fear of movement and stop the fear of pain and those kind of things. I think there's a massive societal question that we need to be starting a discussion about. So I think it's very hard to locate that in a single service. And actually, probably in terms of the question of where exercise medicine can come in, and some of what we were saying earlier, is actually who can you enable to be having those conversations? Who can you upskill? Who can you supervise? Who can you educate in order to be having the conversations around movement? Most of you will know the amazing website of Moving Medicine, where you can put those kind of small conversations about movement into your consultations in all long-term conditions. That's an incredible resource, but the extent to which we do that in healthcare may not be there, because we're all trying to like get through our clinics. But I would just say I can't see that we can locate it in a single service, and we need to have a wider conversation. I don't know if that's a bit of a cop-out, but Imran, you might have some other thoughts.
No, I would completely agree. These are, it's this thing that there's this increasing pressure on healthcare providers to be able to resolve this, and sometimes we even get forced to have to put points in a competitive tender about what a small provider will do about these massive societal and cultural and population issues. And often these are things well beyond the scope of what an individual healthcare provider can do, and these are very, very challenging political and kind of cultural issues, which, you know, whether it's public health, government, I think it's very, very aspirational, but I think it's very, very challenging for healthcare services themselves to be able to deal with it. One of the other big things as well, this is just specifically for a London context, some populations are highly migratory, like the London population. So people don't stay in London, they move in and they move out. So when you are looking kind of long-term outcomes for patients, it does kind of make things very difficult. So there have been various services that people have proposed that, oh, this will reduce this, and it takes 5 years for it to reduce this or that. And so, well, patients might not, a lot of our patients don't stay in London that long, so it doesn't necessarily help out. I mean, just from a selfish perspective of our system costs, when you're trying to argue that this will reduce some costs down the line, that doesn't usually play out in a lot of metropolitan areas where people are very migratory. But yeah, it's very aspirational stuff that we should be looking on, but I struggle to understand how healthcare providers can have a big impact, which, yeah, it probably does sound like a bit of a cop-out, but me just being skeptical, I guess.
Kim, did you want to add if you wanted to?
I was thinking more in terms of, you've mentioned a lot about how SEM consultants are really expensive, that allied healthcare professionals are cheaper. You're looking at, you know, what's our added value? Yeah, I run a predominantly acute service. Yet, how are you looking to develop these services whereby the patient, it links back to GIRFT, so that they have an acute injury, they're seen by the GP, they're referred to physio, they go into a hospital waiting time, it becomes chronic because actually the diagnosis in the first place was wrong. How are you looking to try and reduce the wait? And it has a longer waiting list, because if it becomes an acute injury, that if it was picked up correctly acutely, is not going to become chronic and is not going to cause the knock-on effect of chronic pain, metabolic conditions, you know, and that sort of sequelae down that avenue. What are you looking for in terms of services? If somebody's coming to you with that, because you've talked a lot about chronic stuff, which is a huge part of MSK, and I totally and utterly get that. But there's also another massive strand of MSK that's quite acute, that is not necessarily well managed with current pathways. That will vary, but I was just wondering from that perspective rather than the exercise medicine.
Yeah, and I guess that's why, you know, sometimes we see SEM services that are kind of slotted in around acute services, so kind of EDs and things. I think, Lesley, I'd be curious to hear what your thoughts are. One of my questions would just be around, I think there'll be specific presentations where actually having that early access to a specific treatment will make a difference. Again, my question would be, how do you scale that? Because how do you make sure the right patients get in front of, if there is a specific clinician, whether it's an SEM consultant or an APP with advanced training in managing those acute illnesses, how do you triage the right patients to get there? Because there is such a limitation. Again, if you look at acute injuries and the consultant SEM workforce, there's a big mismatch there. And then secondly, I guess there is that question of, there are definitely some conditions where earlier diagnosis and treatment will make a difference. I guess the skeptical part of me would also say that there have been lots of areas of work where we've tried to ascertain if better assessment early on, for example, back pain is a big one, where we've talked about different systems, where we looked at different systems to try and what's the word? My brain's gone. But when you're trying to triage back pain, sorry,
stratify.
Yeah, sorry, that's the word, stratify. Yeah, so trying to stratify back pain early on to try and prevent that chronic trajectory. And actually, a lot of the high quality studies often suggest it might not have as much influence as we think. That's obviously not the case for everything. There will be some acute injuries where actually having an early tissue specific diagnosis is very important. But yeah, I think for those cases, you still need a system in terms of how. So one of the things we've locally been looking at is trying to have a bridge between, we don't always have SCM in our MSK services, but it's just making sure the MSK services, which are meant to be your single point of access, and also our ED services, are aware that we have a local SCM service that sits within an ED service in our sector, and making sure that there is a relationship, that people know that service is there. If there's an acute injury with the complexity that it's not getting resolved, there's a pathway into that. But yeah, the biggest challenge is just how do you, there's not enough SCM workforce, so how do you just have a single point of access that directs the right patients to that acute service?
Yeah, I mean, I think I would just say that your involvement in an acute service in end-to-end pathway development and making sure that those pathways locally are working well, running well. So you can have a beautifully designed pathway on paper for an acute injury, but making sure that every single element of the workforce, whether they're sitting in, whether it's a junior in ED, understanding that these things are available and can be referred into, or the GPs locally, or, you know, and also is your service open to GP referral? So actually, if I was a GP who thought, actually, this fits with this pathway, and actually an early intervention would be really useful in this context, then I would know. So I think you as either services or kind of advocates for your service, really getting into kind of collaborating locally is really important. I would also say, just as in my experience as a GP, in terms of what leads to chronicity, I think that's really multifactorial. I think that there are some people whose chronicity comes from a load of other different elements and aspects, and I think there's a lot to be said about inequalities in other realms of life that probably have a big influence in that, not just access to acute services. So yeah, I would just have that little caveat in my mind that you can develop these services, and it's good to, and it's important to kind of make sure that we understand how to stratify who needs which service when, and be really involved in that process. But that we won't catch all of those people because there are other elements.
Yeah, that makes sense. Thanks. Yeah. But I think I appreciate what Kim was saying in terms of the GIRF stuff, where we see quite a lot of that as well, where you could have prevented something becoming chronic, but there are so many different reasons for chronic pain, I guess, which is difficult to cover every kind of reason for that. Shall I move on to the next one? So Irfan's asking, we have worked on real life models of care with the MSK playbook, bringing in SEM-led MDTs, complex case discussions, imaging MDTs. It would be great to share this practice and learn from others who are working in this space. What's the best forum to discuss these models with commissioners?
My understanding, I love the playbook, but my understanding was it was mostly, it's kind of an educational strategy. So I'm not sure whether he was talking about scaling it as an educational resource, or if there was actually, it kind of seems to be talking about a model of care here as well with certain MDTs. I don't know if Irfan's there.
Irfan, are you? Oh, you are there. Irfan, I don't know if you can elaborate at all, if you're in a position to be able to elaborate. Maybe not. Maybe we'll come back to that a bit later if Irfan's around later.
Broadly, I think MDT discussions are absolutely the way forward. One of the challenges that we have with MDTs, because they're great in principle, but it's this question of how everyone's really, really busy. So how do you free up time? We've tried to come up with ways to pay primary care docs to come to MDTs. Okay, well, if it's not primary care, could the health coaches, could the pharmacists in primary care come to discuss cases? We've tried to have very multi-stakeholder MDTs where you've got radiologists, orthopods, maybe spinal surgeons, pain doctors, but everyone's job rotas are so busy. So it becomes very hard to kind of schedule MDTs. But I mean, I think MDTs are definitely the way forward. It's just figuring out the logistics of it, and how you actually scale them with every member of the workforce being so busy, or whether it's kind of more of an asynchronous model where we just have other channels where we can communicate. I think a lot of time we just message we have informal networks where we get advice from other specialists, but I think they are generally accepted as the way forward. I think other specialities are perhaps very good at this. You know, oncology is one example where you'll just have a whole day of just MDT and everyone's rota that everyone shows up to. But in MSK, it's been really, really hard to figure out how we, oh, hang on, Irfan's just mentioned something.
Yeah.
Yeah, so I guess he's talking about that kind of model where, you know, primary care or community, I think APPs could discuss cases. So I think it's absolutely the way forward. I think the challenge is just everyone's trying to develop that model, and it's just freeing up clinicians, especially primary care clinicians. And it's done in other areas in primary care. So for example, diabetes, you know, primary care will bring those cases, but other areas of primary care activity have money attached to them. So primary care have financial incentives to improve the diabetes outcomes of their population. There are very few financial incentives attached to MSK or pain management to incentivize. And, you know, there are lots of, you always get a handful of primary care clinicians who are interested and motivated. But if you look at, in my sector, there's what, 1,500 GPs and even more allied health professionals. And we get tiny handfuls that come to these MDTs. And we've had kind of random thoughts about how we could somehow split a virtual tariff to try and incentivize primary care docs. But when everyone is so snowed under, it is hard to, you know, free up people to come to these MDTs. And they're great because it's not the individual, it's not just the individual case. It's also general educational learning for everyone who comes to them. But I do think money needs to be involved in order to actually be able to justify people being freed up from clinical sessions to attend them, unfortunately. But yeah, Irfan, very, very happy to have a chat to see what you've managed to achieve and see what can be scalable.
Yeah, I'd be super interested in that as well. I think it definitely is the way forward. And I think for me, I think the future, this is just my personal opinion, placing SEM in community MSK is, I think, a good future place from an NHS perspective. And MDTs are definitely the way forward. But if I think about some of my colleagues who in primary care, it's absolutely like, what capacity are we releasing from seeing patients in order to then come to these MDTs where we will learn loads and we will be able to then use it for the next patient. So how do we create a learning environment also for primary care in that context where we actually go, oh, okay, actually the last time I discussed a patient like this, it was this, and actually I can use that same learning in this context with this other patient who's similar. But incentivizing that is really important. But also thinking about who are the other roles in general practice who might actually be better placed to come to things like that. So whether it's GPs or FCPs, if your area has first contact practitioners, but also like the health and wellbeing coaches, if we're talking about exercise and behavior change, all of those kind of things, they are also a good group to kind of consider as well. And maybe the way forwards are like communities of practice, potentially, which is slightly different from an MDT. But yeah, it's interesting.
And I do think bang for buck, an SCM consultant probably adds a lot more value in an MDT versus seeing, you know, an MDT maybe you can get through 10 cases in the same time that you might see 2 patients face to face. So bang for buck, it's definitely a very high value, good model of SCM consultants.
Yeah, I think that's definitely something that I've seen work well in some of the community MSK services I've been in, where there'll be a sort of wheelie MDT where you can assess lots of different patients and discuss them. I think it's probably something for all to think about adding into any business cases that we put forward as well, essentially leading an MDT, because that's a big part of where we need to show that we're adding value. So I think so that's all the questions from the floor for now. If there isn't any other burning questions, people can pop in, but sort of interrupting the broadcast very briefly for a bit of a plug and an advert, if that's all right, while people are still engaged. So while we're on this call today, we wanted to just publicise the fact that there's been a lot of work going on by the faculty around workforce planning and essentially producing documents, videos, and a website that's helpful to anyone who is either thinking of putting a business case together, thinking about, you know, how commissioning works, and the models around that. Before I show you the website, just need to thank the people involved in that, because a lot of work has gone into it. So James Brownlee from the faculty, who's on this call, has been instrumental in getting that together. He's put in a huge amount of work and has coordinated a team of sort of busy doctors who have all been chipping in, and he's been really helpful with that. Kate Strachan and Pumi have been really helpful from a consultant perspective in leading that. Myself and Dan from the registrar faculty reps have been involved, and Matteo as well has helped at points, and Natasha obviously sort of overseeing broadly as well. I'll just share my screen just to show people where they can access workforce planning information on the faculty website, which is now gone live. So this is the faculty website as it looks when you go onto the home page, and then if you go into the menu, and then it's under careers and training, and then if you select the workforce planning section, there's now loads of information there, and it's basically split up into 3 areas. So the role of the SEM consultant, within that you've got loads of information that's sort of ready-made and packaged. If you do need to put a business case together, that you've got that, what is the role of an SEM consultant. It's got links to the full MSK workforce planning document, but also it's got some summary documents, and it's also at the bottom of here, it's got links to infographics, so that if you have those corridor conversations with people, commissioners, we talk about networking a lot in this question and answer, you've got a quick reference if someone is kind of looking to learn a little bit more about SEM, what they do. I know some areas particularly don't have a huge SEM presence, and these kind of things can be really useful in getting the message out there. And then just down from that, we've got the setting up SEM services tab, and within that there's more information, and there's a long form interview video with Dr. James Hopkinson, who's been involved a lot in commissioning of SEM services, with a bit of guidance for setting up an SEM service. So similar to some of the bits we've been talking about today, and that's available on the website as well with associated information. And then finally, looking more into commissioning. So again, similar themes to what we spoke about today, and Dr. James Hopkinson's provided another long form interview, which can be watched on the faculty website regarding that. So that is now all available to everyone, just through the faculty website. I would really recommend it as just a good first port of call if you are thinking of going down the route of setting up your own service, or if you're having discussions with commissioners about maintaining or recommissioning of existing SEM services, because a lot of work went into it. Hopefully it will save that similar amount of work for people who are already busy, and hopefully take that barrier away from us all getting into sort of NHS SEM services. So any questions on that, please just email me or James, and we can direct you in the right direction regarding the workforce planning tabs on the website. Just drop us a message afterwards. And then I'll just hand back to Pumi for our last question, really, looking towards the future.
There you go. So we've kind of, I think, Lesley, you've touched on it a little bit, but as a commissioner, how do you see SEM services evolving? Could we just expand that on a little bit more? Would be good to get both of your thoughts on that.
Feel free, Imran. I kind of said what I thought, but I think we similar. You're on mute.
Yeah, I think it goes back to the same thing of you know, what's the narrative of your local ICS in terms of what the strategic needs are, and then, you know, can you quantify and evidence specific issues where there may be either wait time pressures, fragile systems in certain pathways. Like rheumatology is often a big case of having fragile systems with a lot of pressure on rheumatologists who shouldn't really be seeing non-inflammatory MSK conditions, or, you know, there are specific high volume areas of activity on the MSK landscape where, you know, it's just about justifying this as the added value that SEM can deliver. And like I said, I think it is about just delivering a model of care. Often the models of care that I see aren't financially affordable or scalable. You know, we have massive populations. So if someone's just doing a little at least from my perspective, if someone's just doing a little pilot, which might benefit a small population of patients, that isn't, from an ICS perspective, where we're trying to think at scale, that's not what we're really interested in. We're interested in equitable models that can be scaled to provide good value for large sectors, not just something that's just in one primary care network or borough that someone's doing. And that requires innovative models where you are not just sitting and just seeing patients outside of a hospital face-to-face, but you're working with a wider team, you're upskilling a wider team, you're upskilling and supporting primary care, you're reducing the gap between primary and secondary care, you're working as a kind of a single point of access for patients who are, the biggest problem that we have in MSK, all our patients are on multiple pathways at the same time. They're on a waiting list for a neurosurgical appointment, they're on a waiting list for a rheumatology appointment, they're on a waiting list for an endo appointment or a diabetes appointment. And, is there one consultant that can actually deal with their medical comorbidity as well as their MSK issues in a more streamlined way? So it's demonstrating that added value. And like I said, doing it in a cost-effective way, considering how limited the SCM workforce is to do something at scale, which I do think also does require additional skills that, other practitioners like APPs, health coaches, they can do a lot. And so you need to demonstrate what can you do above and beyond those members of the practitioner workforce to justify the cost.
Yeah, I mean, all of that. And I would say that that MSK and just generally MSK healthcare is much bigger now on the national agenda. So I would say that this is a good time and a good opportunity time for SEM services within the NHS. So and like I said, I think where you situate yourself is probably really key, or where you kind of propose to situate yourself is probably really key in that kind of getting commissioned or not getting commissioned. So yeah, I think it's exciting. I think I need to go and look a bit more into it now.
And I think in reality, I think every SCM consultant kind of usually has a specific interest or niche. So, we're talking about kind of very broad principles, but there will be endless roles out there. Whereas if you have a network of commissioners and people in different, whether it's in specialist centralized commissioning, whether it's in secondary care, whether it's in community care, whether it's something in a integrated neighborhood team, it's just about having a network and seeing where the opportunities are. And everyone just finds their own niche that relates to, everyone has specific types of things that they like to see, whether it's the acute presentations, whether it's the chronic presentations, whether it's interventions that they like doing. So it's just about trying to figure out who are the people I need to speak to try and find a role where I can justify spending my money on me and that I can somehow demonstrate value for the system, which, like I said earlier, will almost always be a cost pressure. It's, you need to justify the additional costs that you're very rarely going to release money from the system. Sometimes you might, be very rarely. So just some narrative, either a narrative which fits the ICS, or maybe you can quantify some evidence, say this is actually leads to better patient outcomes, or for this cohort of patients will have better cost outcomes or something.
Brilliant. Any other questions in the chat? Now is your chance. Otherwise, we'll wrap up and say our thanks. Okay. Yeah. So I just really want to extend a huge thank you to Lesley and Imran for giving up their evenings to come and speak to us. We've had a really good turnout and participation for this, and I know a lot of people were very interested in coming to this because it's a topic that is talked about a lot, but we rarely get face-to-face with people like yourselves. I know some of the things that I've particularly taken from this is really about tapping into that local need, and also that there is maybe a bit more of a political element to some of the commissioning than I maybe realised before, and definitely to consider that when thinking about putting business cases together in future. Thanks as well, PUME, for organising this. A lot of hard work's gone into getting this together at relatively short notice. So I just want to extend my thanks as well to PUME, and thanks to everyone for attending. The session has been recorded, so that information is going to be made available to everyone, and obviously it'll be made available to anyone who was unable to attend as well. So thanks, and we'll let everyone sign off.